Welcome to the Immune Edit. I'm Dr. Doug Jones. If your immune system feels like the enemy, or you're just tired of not feeling like yourself, this space is for you. Welcome back. I'm so excited today for our guest, Dr. Alice Hoyt. And I was actually on her podcast not too long ago. She has an amazing podcast. I had so much fun with you. Why don't you introduce yourself to this audience, as we may not share the same audiences, but go ahead and tell us who you are.
Yeah, thanks so much for having me, sir. So I'm Dr. Alice Hoyt. I'm a board certified. I'm from the South, man.
All right. Go ahead.
So I'm Dr. Alice Hoyt. I'm a board certified allergist, immunologist, also board certified in internal medicine and in pediatrics. I own my own practice, the Hoyt Institute of Food Allergy, and started my practice in 2021 after my family and I moved back from Cleveland. I formerly at the amazing Cleveland Clinic, also was on faculty at Vanderbilt University and did my allergy training at the University of Virginia. So super excited to be back in my home state, sharing so much about food allergies. And then when I'm not seeing patients, it's my clinical world, then we do a lot of outreach with my nonprofit Code Anna. We equip schools for medical emergencies. Thank you for having me.
Absolutely. Actually, why don't we start there with the Code Anna? I'm involved in this project now, and I think it's an amazing work that you're doing.
Thank you.
And so I want our audience to know right off the bat, like, what that is, and then we can kind of dive into what I wanted to talk about today.
Absolutely.
But tell us about that.
Yeah. So Code Anna is a 501c3 nonprofit organization that started, I started it when I was a fellow at UVA. And it started because Dr. Platzmills came down the hall in our research building and said, "Alice, will you please go to the school and teach them about EpiPens?" I said, "Sure." So I had done a bunch of teaching with schools for years and years. So this was definitely in my wheelhouse. I was very excited to do it. Went to this lovely school in Charlottesville where there was a lovely nurse. And I said, "What's your medical emergency response plan?" And it wasn't as bam, bam, bam as what I'm used to. Having done internal medicine and pediatrics residency, I did a lot of intensive care unit and had unfortunately, a lot of codes. And so in a code situation, in a hospital, everybody has a job. There's closed loop communication. There's a plan in place. You practice these plans. And I was just very surprised that in general, schools didn't have robust medical emergency response plans like they have for fires. And we know that a medical emergency is much more likely to occur in a school than a fire, right? And that's in part because of all of the planning and advancements that have gone into fire safety and fire prevention. And so that's when I started Code Anna, because even though that particular nurse's question was really how do I get the EpiPen to the child? How am I supposed to know when the child in the cafeteria or on the playground is having an allergic reaction? What really the underlying issue was there was not a clear medical emergency response plan and a team to support that nurse, especially in schools where there is no nurse, right? And so that's where Code Anna came from. We equip schools for medical emergencies with an emphasis on anaphylaxis because I'm an allergist. We also do a lot now with hands-only CPR, have an amazing program with the state of Louisiana Department of Public Health with Call Push Shock at School, where we're teaching all the school staff how to do hands-only CPR. You don't have to do mouth-to-mouth anymore to really have an effective response in most kids and adults. So that's what we do. We also help facilitate, and you've been so lovely to participate in helping schools and non-school entities acquire epinephrine auto-injectors. This is called stock epi, or epi that is stocking a specific entity. It's not prescribed to a person. It's prescribed actually to an entity. And so Code Anna helps facilitate that. You have very generously donated your time and the power of your signature to help entities get these devices that ultimately absolutely save lives.
That's amazing. Tremendous work that you're doing, and so needed. And it's kind of incredible to me how overlooked it was. It's now in retrospect, it's well, that was obvious. How did we miss all of that? And how did we not have any of these things in place? And I'm so grateful that you also noticed that years ago and was able to kind of create a solution for that.
Thank
And I
you.
want to make I want to make people aware that this program exists. And yes, we are working to help get stock epinephrine into schools and non-entity schools, and it should be.
Yeah.
Uh, you look at all of the AEDs in the world, and
Mhm.
I mean, I thought for years as I was walking through airports and various places, we have all these AEDs, and I often thought, why don't we have Epi? Because you're far more
Mhm.
likely to use Epi than you are an AED, and it's every bit as the emergency. And so
Right.
this program is awesome.
Thank
So I want
you.
to very much make people aware that this exists. Also acknowledge your efforts in championing it. And how can people kind of tap into this if they're listening and they're like, oh, wow, we want that for our school or we want that for our entity? What are the steps that they would take?
Yeah, so go to codeana.org, CODEANA, one N, like anaphylaxis.org. Shoot us an email or go to Instagram or Facebook, send us a message, and we can help you get going on next steps. Also, it's also very you can do it yourself online if you need to go get trained on how to use an epinephrine auto injector. If you need to get trained on hands only CPR, you can go to codeana.org, and in the top right is the call to action to get trained, and that'll bring you to our learning platform. And that's where there's just so much education on there for people to just really dive into what do they need to learn. And it's really focused on non-medical professionals, and that's where I really saw the gap was that even though that school had a nurse, her team we're not medical professionals. And so many times in the community setting, especially when we're serving kids with food allergies, they are surrounded by people who are non-medical professionals. And you and I talked about that on when
Yeah,
you were on my show, was that,
yeah,
they're with us for a very small amount of time compared to when
yeah,
they're in the wild, as the cool kids
right.
say, right?
Yeah.
And so it's important that we prepare every layperson or non-medical professional for how to prevent, recognize, and respond to a medical emergency.
Yeah, and nowadays with schools being underfunded in a lot of situations, their nurse is having to manage many schools, and
Mm-hmm.
so there's often not any kind of anyone with that medical training,
Right.
and so they're having to travel around from school to school and manage many schools, and they're stretched thin.
Mm-hmm.
And but
Absolutely.
we can empower lay people. We can empower people, with proper training to do this. So I think it's an
Mm-hmm.
amazing project, and well done. And
Thank you. Thank you for being
hopefully,
a part of it because,
yeah,
as you know, one of the barriers to entities, schools, restaurants, whomever it may be, one of the barriers to getting devices is having a doctor sign the prescription because it is a prescription.
right.
And thank you so much for stepping up to say, oh, yeah, I'll sign that. Thank
Yep,
you.
absolutely. And I know we've been able to get that into a few of our schools here locally, and
Mm-hmm.
it's awesome. So well done.
Thank you.
Um, and hopefully, people that are listening, if you see that need in your community, go to the website Alice had just mentioned or the Instagram and get involved
Mhm. Yep.
because it's a beautiful way to get prepared. I have a saying. It's called the six P's, and I have two versions of it. I have the OG version. It stands for proper prior preparation prevents poor performance.
I love it.
Then I also have a positive version of it that I modified it to, and it's proper prior preparation promotes peak performance. And so, on both
Yes.
sides, what you're doing with this is all about that proper prior preparation and
Yes,
and helping people
absolutely.
prepare ahead of time so that when that emergency arises, we're having peak performance in that time.
Yes.
So yeah,
And
it's
isn't that
awesome.
just so relevant to especially what you and I do? We spend a lot of time talking with families, providing evidence based information, but
Hmm.
then it's that anticipatory guidance
Yeah.
of what to expect, how to manage a situation that I find is just incredibly important to serving food allergy families.
Yeah, agreed. So well done. Um, what's interesting and what I kind of want to transition to for our conversation today is, I mean, I think you and I met maybe virtually a few years ago,
Mhm.
met in person just a couple of years ago. But what's fascinating is both you and I simultaneously in parallel and without knowing kind of transitioned both of our practices into a new phase.
Mhm.
And our thinking was actually very much aligned and alike. Um, but some of it was maybe out of choice, but also some out of necessity. And I want to talk about kind of the evolution of our practices, but also just the evolution of what's having to happen in general. And what I
Mhm.
mean by that is, take for instance, just last week, received an email from our national college, the American College of Allergy, Asthma, and Immunology, who are doing some great advocacy work
Yeah.
on our behalf. And
Yeah.
what happened was United Health came across and said they're now going to limit skin tests to only 20 tests per 365 days.
Mhm.
And on the surface, for those in the audience, they may not know the significance of what that single thing may mean.
Yeah.
But what that means is very detrimental to patients, first and
Mhm.
foremost, and allergists. And I don't mean to put you on the spot, but with that, just that single change, which comes at the heels of many changes over the course of decades of insurance saying, docs, you've got to, we're going to take more away, more away, more away, add to your burden of
Mhm.
overhead.
Mhm.
And the answer, by and large, is never insurance needs to change. The
Mhm.
answer is always doctors need to do less with more, or do
Right.
more with less.
Right.
And this change underscores all of that. And I
Mhm.
want to first just kind of get your initial reaction to it. And also, did some of these things kind of play into your evolution of care, and what is kind of like what you do look like now?
Yeah. So I'm a very risk averse person and I like to be in control. And so when I first opened my practice here in New Orleans in 2021, it was after I had my dream job at the Cleveland Clinic, and I helped launch their food allergy center of excellence, learned a lot about the business behind the scenes of how to really make an excellent experience for patients, but a sustainable one. And when I relocated because of my husband's job, not because of my job, but when I relocated, there was not the same appetite down here for food allergy like we had at the Cleveland Clinic. And,
Pun intended.
right, well done. Well done.
Okay.
So there wasn't that interest, appetite, enthusiasm. And so I said, I'm not going to take time away from my family. I had a little girl at the time. Now I have a little girl and a little boy. I didn't want to take time away from them to see patients who are dealing with important conditions, but conditions that I am not like super enthusiastic about treating. I am like all in on food allergy. That's all I want to do. That's all I do now. I am like jazzed about caring for these families. It doesn't mean that I don't care about asthma or atopic dermatitis or seasonal allergies or spontaneous hives. I do, but where my wheelhouse is food allergy, and it's taking like the research and applying that to our patients now and providing them with the most up to date protocols that could work for them. And honestly, that takes a lot of time, effort, brain power to be like super niche down and provide that level of just the best possible care that I can possibly provide. So if I tried to do that in every area of allergy, I would fail. And so I went where my passion was. I went where I felt I was called to serve, and that really is in the world of food allergy. Now, when I was starting my practice, and again, I needed to start a practice because no one was really interested in this like niche food allergist, even though I'm board certified allergy, immunology, internal medicine, pediatrics. Like I have a reasonable CV, I would say. Like at the end of the day, the hospital systems, they want to hire somebody who can be productive for them. And they were not seeing that food allergy was going to be productive, right? And so I said, okay, I need to start my own practice. But I was terrified of these things called clawbacks from insurance companies, of where, a few years later, they're going to call you up and say, oh, actually, we overpaid you and you owe us tens of thousands of dollars, like I hear about from our colleagues.
But if they
And
ever underpay you, they won't come back and make up for that.
right. Right. No, of course not. And then also of note, as I hear from some of my friends who are still in the insurance model, especially like surgeons, things like that, um, they don't pay promptly. And so they're holding on to this money for months and months and months and months. You're trying to pay your staff, especially if you're a small practice. And there's a lot of value in a small practice. There's a lot of value in large institutions too. There are pros and cons to all these different types of healthcare structures. When you're a small practice, you don't have a lot of wiggle room in there. And so it's really hard when you're not being paid in a timely fashion. And then when you finally do get paid, like you don't get any interest on that they've been holding out for 3 to 6 months, right? Meanwhile, you're trying to make sure that you pay your staff. And how many times do I hear that doctors are the ones like taking a cut, taking money out of their savings so that they can pay their staff, right? Like
Yeah,
we shouldn't be in this situation. And even
right.
when I did look into, okay, well, maybe I could take some insurance, what the insurance company was offering to reimburse me for a complex visit was not conducive to me being able to keep my lights on, much less pay my team.
Yeah.
So how it would be conducive is if I were seeing 4 patients an hour, meaning seeing a patient 15 minutes, 15 minutes, 15 minutes, 15 minutes. And that's not how I want to practice. That's not how I feel that I even can practice. I need to sit down with people, have a conversation. If I'm going to provide a care plan that involves giving a child something that they're allergic to that has potential risks, right? I need to have a really good relationship with that family. And I can't get that in 15 minutes.
Yeah, that's echoes so much of, kind of my journey and what I went through, and a lot of the same feelings of you just
Mhm.
can't get that done. And
No. And patients
is
don't want it either. They get so annoyed, right? Like, I mean, I get annoyed when I go to the doctor, I wait because they're running behind, which is fine. I will wait for hours for a good doctor, right? Because
yeah,
usually if I'm waiting for hours, it's because they're spending time with their patients.
yeah,
But then in those cases where you feel like the doctor just sat down with you for 5 minutes, like it's
behind a
not the
computer
way.
checking insurance boxes.
Oh my gosh. Oh my gosh. Um, that is just not right. Like, that's not the way healthcare is supposed to be.
Yeah,
Healthcare is that way because of health insurance.
yeah,
Electronic medical records were sold to us as a way of, oh, we can see our patients' care. We won't have to double order tests, blah blah blah. Like it'll be so great for the patients. It is
mhm,
a massive billing machine.
yeah,
And it breaks my heart when I hear my colleagues talk about they're going home at night, waiting till their kids go to bed to then spend an hour doing their documentation, not because it's in the best interest of the patient, not because they need to write more to make sure
right.
they remember what the treatment plan was. It's to make sure that they get reimbursed or their health system gets reimbursed for the excellent care that they're providing. It is it is it is not sustainable, as I think like you and I were talking about offline. Like we are reaching a point, this is not sustainable. Doctors don't like it, patients don't like it. And to your point earlier about the skin testing, why that's really important in allergy and what some people don't necessarily understand is that allergists in a way are able traditionally to spend a little bit more time talking to you as opposed to like a primary care doctor who really we want them to spend time talking to us, but the more you talk as a doctor, the less you're being productive. the less you're generating revenue. And so, because allergists do skin tests that do get reimbursed, then they're able to, that offsets them being able to spend a little bit more time with patients than somebody who doesn't have any other procedures that help them keep their lights on, that help them pay their staff, that help them feed their own families. And so when a health insurance company says, well, we're only going to let you do 20, well, how, first of all, how is that not practicing medicine? You're saying that this patient only needs 20. That is
Right.
that is making a medical determination, a medical assessment, and that is inappropriate. But that has somewhat been litigated, that health insurance plans are not practicing because the patient can always pay out of pocket, right? But we're in such a bad place in healthcare, and I hate being all doomy gloomy, but it is causing more and more very good doctors to say, I can't practice like this anymore. I'm moving to the direct care model where I am charging the patient pays me or my practice. We do what's called a super bill, where we have an ICD-10 code, the CPT code, all the codes they can submit to their health insurance. They can do FSA, HSA, everything possible to help them take advantage of their health insurance, short of me working essentially for their health insurance company.
Yeah.
That is not a place that I can be and serve them the way I feel called to serve. And I'm getting from so many other docs, they're getting put in the same situation because the health insurance companies are not, it's not these doctors are being greedy, they're not. It has to be
No.
sustainable, and it's not.
Yeah, I know of one well-established large practice. Uh, they'd been a group of allergists practicing for 20, 30 years. Um, they weren't mismanaged, but they had to close their doors, within weeks because they couldn't cover the overhead, ended up getting in some debt. And again,
Mm.
it wasn't out of solely being mismanaged or something negative of that nature. It was just the simple fact of the ever decreasing reimbursement from
Mhm.
insurance, but yet
Right.
the ever increasing costs, the costs of
Mhm.
supplies, the costs of staff, the cost of insurance, the um,
Right.
costs just to get paid. As you mentioned before, we have to
Yeah.
hire layers of people just to fight to get paid. All of those
Mhm.
costs just rose so much, and now they're trying to take away more and more. That practice I know closed their doors. I know of
That's
another
so
one.
sad.
Yeah, I know of another one. Again, well run, smart people reached out to me and said, "Hey, we're looking at going at direct care. We know you do it. We're in dire straits because we can't cover our overhead anymore with what's going on. We don't know what to do. We're trying to find ways to serve our patients. What do you do, or how do you even do this?" And so there's kind of this flow where it's almost like you're being forced out of practice by
Well, it
insurance.
is. Well, it is
Yeah,
because what some people might not realize is that it's not that an insurance company will reimburse. And when we say reimburse, that's because I see, like, let's say I did accept insurance. I see the patient and I provide care, and then I submit to the insurance company that I provided care that had a value, a dollar value, and then they
yeah,
reimburse me. Like, I already spent that time, which was a value. So then they're reimbursing me. So that's like
right,
a nice way, some sort of euphemism, reimbursement. Um, but they are being forced out. Private
right.
equity is coming in. The big
Yeah,
health systems are gobbling them up because me, this like N of one little doctor, I don't have the negotiating power to say, no, that reimbursement is too low. I need a higher reimbursement. They don't have to do that, right? I have zero negotiating power as opposed to
right.
the bigger facilities. On top of that, let's talk about facility for a minute and the concept of a facility fee that some entities can charge. And because they can essentially get paid more because they're a larger facility. They the thought is that, oh well, they have access to more easier ways to access the different things that you need, like in a big like hospital or whatever.
Hmm.
But I've also had colleagues tell me that they specifically have had patients tell them, well, I don't want to go to the main campus because I'm going to get billed that facility fee. And so now patients are starting to see this.
Yeah.
I think initially, and still, I think a lot of times it gets turned to us, like we as doctors are charging more. We as doctors don't want to sit down and spend time with patients. But I'm hopeful that now, especially as like you and I are talking about it and sharing this publicly on a podcast, that that's really not the case. Yeah, sure, there can be some greedy, just bad people doctors out there.
Sure.
But for the most part, it is people who dedicated so much
Hmm.
of their lives and really valuable parts of their lives too, especially with more
Yeah.
women in healthcare. The time where, traditionally they might be at home having babies, now they're putting that off to learn how to be a doctor, to take care of people.
Yeah.
And this is where we are, and it's so wrong. It's so wrong.
It is. And one other aspect that I want to touch on that's also a part of both of our practices is telehealth,
Hmm.
actually.
Yeah.
So um, during COVID, I think a lot of us started doing telehealth because we had to. Not
Hmm.
everyone. I did. We started doing a lot of telehealth, and thankfully, at that time, a lot of the insurance regulations were lessened. It
Hmm.
was kind of relaxed, and we were allowed to, for instance, see allowed by insurance to see certain patients and do certain things that made it realistic.
Hmm.
And what's crazy is there's also some groups. There's a really great lady who's an asthma educator in the state of Utah, and while we were doing a lot of telehealth in remote Utah areas, for instance, because that's where I practice, they were collecting data on asthma outcomes. And it showed that, their data was really nice. And it showed that by people being able to access telehealth, they were able to have much better asthma control, much
I
better
bet
asthma
they were.
outcomes, right? Because they're actually following up and they're
Right.
having those touch points. And we were
Yep.
able to do that. Well, as we were coming out of COVID, all of a sudden we start hearing, well, insurance is not going to allow this and they're not going to allow that. And all of a sudden the barriers were coming back up
Yep.
and the reimbursement was going to get less and they weren't
Hmm.
going to pay as much and all the things. And I went with a group to Washington, D.C., met with, at the time, our Senator Romney, Mitt Romney's office. And this group pitched like, wait a minute, don't put the barriers back up. Don't
Hmm.
decrease the reimbursement because we're showing we're getting better outcomes.
Yeah.
And the staffer person that I talked to literally looked at me and was like, I don't care. We don't care. This is all about money, for the insurance. And I was shocked at how candid they were with me on
That's
that.
because they have never sat with a mom, with a dad, with a
Yeah.
patient
Yeah.
and had to provide any sort of care. They have never
Right.
been directly accountable to any patient. They don't get
Right.
it.
They don't. But what I also started seeing at that time is I'm like, wait, we've been doing this and serving these patients in a really effective way, taking the care to them. And then
Hmm.
also what happened in my practice, and I know you're solely food allergy. I do obviously a ton of food allergy, but I also started taking care of a lot of really sick people that were
Yeah.
getting complex neuroimmune issues, from long COVID,
Right.
uh, various issues with vaccines or whatever. And so um, some of these patients, or like MECFS, some of these patients are so sick, they can't travel. They
Hmm.
can't do those things. And,
And what a
or the,
luxury too to be able to travel.
right,
let's say that it is
It is.
we're very blessed to be. I was thinking about this the other day. We're very blessed to be able to just get in our car and drive to Chick-fil-A.
Yeah,
We live like kings. We are so blessed.
right.
And some people can't do that.
They
But with
can't.
telehealth, we can still provide them best care so that
Right.
they can, if their health is better, then their whole life can be better.
Yeah. So I made a decision there. Well, I'm not dealing with insurance regulation because doing
Mhm.
telehealth was insurance regulated. It became now near impossible because of all the reasons we did. And I was like, no, but these patients deserve care. And so that's where I kind of shifted to direct care, but
Mhm.
also with an emphasis on a hybrid clinic of being able to see patients in clinic, but also with an emphasis on telehealth so that we
Mhm.
can make something affordable,
Yep.
accessible, convenient, but also deliver care to people who may be lost in the cracks, who
Yep.
may be in a remote area, unable to travel, too sick to travel, or even on a food allergy front, with a busy family,
Mhm.
not able to travel to, their doctor's
Right.
offices week in and week out. It's like, well, no, we can do
Right.
this from home,
Yep.
and so trying to, in a very affordable way, bring care to the patient and I've tried to evolve the practice to where we make it more convenient, more affordable, but also our life in terms of sustaining our own peace, not only peace of mind, but our own sanity and
Mhm.
being able to
Yeah.
take care of ourselves, to
Yeah.
uh, take care of people, and
Absolutely.
it's been a really big part of it. But I thought it was fascinating just watching insurance over COVID, where certain things were allowed during that time, and then all of a sudden, oh no, COVID's over, we can't allow that anymore. Why?
Yep.
There was no reason for it.
Nope.
But
Nope. No, it's an interesting state in which we're in regarding healthcare. And as I mentioned to you earlier before we started recording, being at the FAST OIT conference last month,
mhm,
I was delighted to be sitting with, I don't know how we grouped together, but we happened to group together at just a table of ladies who are either doing direct care or about to be doing direct care and moving in that direction. Whereas when I started, it was very rare that somebody was doing direct care. It was really thought of as
mhm.
like, oh, concierge, like that show Royal Pains, and it's very like bougie and fancy. And that's really not direct care.
It's
Direct care
not.
is just very accountable care, I would say. And we are making it feasible and reasonable and working with families to get them the care that their kiddo needs and doing it on terms that in my opinion are the right terms.
Yeah, I agree, and this is partially why, I mean, mainly why I had wanted to have this conversation with you in particular, because I think currently healthcare is at a breaking point,
Mhm.
especially in kind of the allergy community. Insurance is doing their hardest to, destroy our specialty, really, and in my opinion, but there are a number of allergists, I think, trying to champion a new way for patients.
Mhm.
And as we talked at the FAST meeting, I really felt like you were one of those people that was able to really create a new solution and offer something not only to maintain your sanity, but
Yes.
in your life, but also provide an immense service to your patients and a meaningful service. And I really like the word you just used, an accountable one. And
Mhm.
and I try to do the same. And I think it's important that also we have this conversation so that patients do understand we hear the challenges. We hear the desire to want to use insurance.
Mhm.
And our practice, much like yours, tries to give every benefit that we can to allow people to either file as a non-covered,
Out of network.
provider Out of network,
Yeah.
yeah, that's what I meant. Like out of network provider, provide them the invoice, provide them those things,
Right.
but also order tests that through insurance lab work that they can run through their insurance,
Yeah.
and working through their insurance and prior authorizations for their medications and all of those things.
Mm-hmm.
But also in the nature of we want to offer a more accountable, valuable service, not concierge. Like this isn't some bougie thing, but it's like a valuable, accountable service to where we can take care to you as well, and
Right.
really offer some things that perhaps others can't. And I wanted to kind of highlight you and your practice today and kind of what you're trying to do, because I think it's amazing. And I think it's
Thank you.
amazing of what you're doing. And we have a very similar model.
Yeah.
Um, so,
It's
uh,
amazing, right? Because we
yeah,
really don't know each other very well, but to see
right.
like how we have seen problems and have identified similar approaches to solve that problem. And I want to
Yeah,
say two more things. One about the skin test thing. It's
yeah.
not to say, I want to be very clear that it's not that doctors were ordering tests that they shouldn't be ordering, or that I'm advocating
No,
for doctors to order unnecessary tests. I'm absolutely not. Health insurance should not, no one should dictate what test is ordered. The only
right.
one who should be able to order a test or make recommendations on what should be run, what shouldn't, is a doctor. Is
Yeah,
a doctor who has gone to medical school, who has done internship, residency, fellowship.
yeah,
Um, I love nurse practitioners. I love physician's assistants. Still, when we're practicing medicine, it's coming back to the doctor, and it needs to
yeah,
be the doctor who is expert trained in the field to provide the care. And the insurance company should in no way, shape, or form be dictating that, except that they are for profit or even not for profit, whatever they are an organization that is made up of members who are participating in this plan so that they can not they can only pay X amount, right? And they have all these benefits, right? Health insurance is a
hmm,
benefit when we get a job, right? It's a benefit. And that's how they are able to operate. They're
yeah.
they're not trying to provide the best care for each individual patient.
Right. I want to know where they come out with the number 20, first of all, because if somebody has environmental allergies and food allergies with a limit of 20 tests, an allergist cannot reasonably construct effective immunotherapy, which is disease modifying therapy.
Right.
The
Right.
rest of all of we do is band-aids for allergy symptoms, not actual allergies, but we can't effectively construct disease modifying immunotherapy off 20 tests per year, especially in that group that has both environmentals and foods.
Hmm. Yeah, and one of the reasons that the in-network insurance model was never going to work for me. Oh, the other thing was about accountability. So I'll come back to that. Was never going to work for me or work for my practice is because I'm literally just doing food allergy. And if I'm doing food allergy well, I'm not ordering 40 tests, right?
Right,
I'm being very specific about what I'm
right,
ordering. And at this point, I don't even do a lot of skin testing anymore. I lean a
right,
lot into our labs, our component tests.
right.
But if you're doing allergic rhinitis, allergic asthma, you need to have your full scope of tools, which is doing often more than 20 skin prick tests to identify
Yeah,
what are allergens so you can formulate that specific patient's immunotherapy to desensitize them to these allergens so that they don't have, and it's not just about itchy, drippy, sneezy, though that can absolutely just, fixing allergies can change a person's life. And that's
yeah,
why seasonal allergies. And that's actually what got me really interested in allergy. One of the things was that, oh, just starting a nose spray changed this patient's life when I was in residency. I was like, well, this is really cool. And it's about doctors being empowered to have the tools they need to use without any in between them and the patient. And the accountability part is that it really is about providing accountable care. And
yeah,
when our poor colleagues who are reimbursed by insurance, they are held accountable by that
Hmm.
insurance company. They
Yeah.
right there, what they're submitting claims to get reimbursed for, like they're held accountable if they submit something incorrectly or whatever the case may be. They're held accountable. They cannot necessarily prescribe a medication that's not on that patient's insurance plan, except, oh, wait, they can, but the patient's going to have to pay for it, which is like not what we want for our
No.
patients, right?
Right.
But
Right.
then they also have that accountability to the patient. That is the problem, is that how do you have accountability to this organization, this entity that's paying you, and also be accountable to your patient? It is an ethical dilemma. It
Yeah.
is a dilemma
Yep.
because who who are you serving? Who are you prioritizing? You have to prioritize your patient. You have to.
Yep.
Sometimes the insurance company is strapping you in ways where you can't prescribe the medication, or it's not covered, or you have to prescribe a medication and then go through all these hoops just to get your patient the care that you as an expert know they need. And the other thing that I that a lot of people don't realize is that it the caliber of clinician that you see is of no value when it comes to reimbursement.
Right.
You can see somebody who is an expert in their field, or you can see somebody who saw a couple of patients in residency, and the reimbursement is the
Yeah.
same. In
Well,
what other field is the quality, the caliber, the expertise so not valued?
yeah. My wife's an OBGYN, and she literally just last night, showed me a referral she had sent over to a specialist. So it was a specialist referral at a university. So kind of high level specialist university referral. And when she got the note back, it was a second year pediatrics resident that saw the patient.
Oh my.
Not even in the specialty. It was a second year pediatrics resident that ultimately saw that patient.
Which, I mean, have residents involved in the care? Absolutely. More eyes, the better.
Right.
Training, yes, please. But
Right.
at the end of the day, it, it this is we're not where we need to be, Doug. That's why we're
I
having this
know.
conversation,
This
isn't
is
it?
why we're having it, and the thing I like is because I'm not one just to. I don't like just sitting and complaining about everything. I always tell people, if you're going to complain, come with a solution.
Yes.
Um, those two things have to be hand in hand, and I think what we're trying to highlight today is there are some major breaking point problems, massively surrounding insurance. And I'm tired. I'm kind of fatigued at this healthcare crisis. Everyone just continuously saying, doctors, you need to do more with less. We're not the problem, by and large.
We are
I
not the
mean,
problem.
yes,
And
there's the
doctors have not had an
outliers.
increase in pay in, what is it, two
Ever.
decades?
Not in my
It's something
career.
absolutely bizarre. Meanwhile, there's more and more admin, more and more bloat to the system.
Well,
And then,
everyone's
well,
wages have gone
let's
up.
fix the problem with,
Right.
let's not train more doctors. Let's train more advanced
AI.
practice providers. Oh, and AI. AI I think can be a great tool, but at the end of the
Yeah.
day, like, you need a doctor. People go to hospitals in clinics to see a doctor, right?
Yep.
So, and again, it's not to say that these other healthcare professionals, these other clinicians don't play an important role. They absolutely do. They absolutely can. And they can absolutely specialize in areas. I know some amazing ones. But
Right.
at the end of the day, if a patient has an allergic condition, they need to be seen and evaluated by someone with expertise in allergy. And the best expertise is acquired through an allergy fellowship.
Yep. Agreed. So
Wow.
we're faced with
Great
these
talking to you.
problems. But on a positive note,
Yes.
I believe you, me, and kind of our band of colleagues are really trying to create some reasonable, accountable solutions for patients. So
Mm,
we're not just sitting here complaining about things. We are doing
yeah.
things and trying to create solutions for patients,
Yeah,
given the circumstances. And I don't want people, I guess we always end a podcast with what we call edits of kind of one or two kind of pearls or edits that people
love
can
it.
take away, kind of just those key things they can take away from their practice. I'll say one, and then while I'm talking, you can kind of think about the one or two things that you would make a suggestion for people. Um, the one thing I would say is, if you come across a doc that's transitioned to direct care, I would say don't necessarily just dismiss that. We
Hmm.
do understand fully the pain that you feel with wanting to use the expensive insurance that you're paying for, but there's also large deductibles. There's still a lot of out of pocket costs. What are you getting for the value? In that you just highlighted beautifully, and really kind of look at the overall, especially if somebody's offering telehealth. Are there travel time costs that are saved because somebody's able to offer that, especially like in an immunotherapy food allergy program?
Right,
If you don't have to travel, if you don't have to do those things, there are a lot of savings that maybe we're not quite thinking of,
right.
with time away from work, time away from school,
Oh, yeah.
travel, all of those types of things. And so I'd say don't just automatically dismiss it. My edit would be really look into it, really think about it, because those of us that have transitioned into that, I feel like are accountable, are trying
Hmm.
our best to offer that valuable service. And
Yes.
there's a lot of really well-meaning people out there trying to solve the problems amidst the challenges that we face. And so that would kind of be mine. But
Absolutely. Oh, I love it. I love it. No, I
thanks.
love that. I think my edit would be something that I try to live by and I fail at it, but I try is give grace, receive grace. And so when you're going to your doctor, whether they're in network, out of network, whatever the case may be, they're a person and they have dedicated and given up so much of their life. And that's why a lot of doctors are invested in trying to find solutions to this. And they're not just walking away from
Mhm.
medicine, though some are
Right.
retiring early, right? But
Yeah.
give grace, receive grace. Like when that doctor is late or when that doctor like seems to be distracted, like try to give them grace and ask them questions and how was your day, right? And I know that that's not why you're going to receive a service, um, but please just remember to give grace and then to also receive grace. Like when you are running late or when something does happen and someone's like, it's okay. And the lady at the front desk or the man at the front desk is like, we see that all the time. Then like accept that and like, oh, okay. Especially the moms out there who having some sort of guilt about something, receive that grace, right? Feel that and share that and pass it forward. And the world would be a much better place.
Wow. I love that. I love that. What a beautiful positive note to end on. Uh, Give grace, receive grace. Absolutely love it. You're amazing. Thank you for joining today.
Thank
And
you for having me.
I look forward to collaborating on a lot more projects with you. I
I
think
love it.
we're very like minded, and I think there's still a lot of good service and work we can do in the world. So,
We're just getting started.
yeah. All right. Where can people find you, real quick?
At Hoyt Food Allergy is our Instagram, and that's probably the best way.
Great. Please go find her. Amazing colleague, amazing allergist, and you know, become a good friend. So, thank you.
Thank you.
Thank you so much again for tuning in. We'll see you next time on The Immune Edit. This show is separate from my clinical practice at Global Allergy Immune Network. This show represents my opinions and my guests' opinions. Neither myself nor the show endorses the views or statements of my guests. This show is for educational purposes only and is not a substitute for professional care by a doctor or other qualified medical professional. This show is provided with the understanding that it does not constitute medical or other professional advice or services. If you're looking for help in your journey, please seek out a qualified medical practitioner. It's important to have someone in your corner who is a trained and licensed healthcare practitioner who can help you make changes, especially when it comes to your health.